I have managed dozens of severe asthma cases, first as a paramedic in the field and later as an anesthesia and critical care physician managing near-fatal events. And the same pattern keeps showing up, and the first time it happened to me, I missed it. Not because I didn't know asthma, but because it did not look dramatic yet. The danger was there the whole time, I just didn't see it. And I've never forgotten that lesson. So in this video, I'll show you how world-class paramedics handle asthma attacks before they crash, how they spot high-risk patients early, decide when basic treatments is not enough, and escalate before they're forced to. We'll break it down into 3 parts. What to assess first when the patient still looks okay, which findings are falsely reassuring, and how experienced clinicians adjust management when the trajectory is wrong. Because if you miss the early signals, the next thing you see might be severe respiratory failure. Here is the uncomfortable truth. You don't miss a severe case of asthma because you don't know how to assess someone's breathing. You miss it because a severe asthma attack can lie to you in the early stages. We're trained to look at 3 things: oxygen saturation, expiratory wheezing, and workup breathing. And in asthma, all 3 can fool you. Let me explain how. First, oxygen saturation. Pulse oximetry feels objective and reliable, but remember, in asthma, ventilation fails before oxygenation. SpO₂ rises, air trapping worsens, and muscles fatigue, while SATs can still look fine. So if you're waiting for low SATs to tell you it's serious, you're already behind. And there's a second way oxygen saturation can fool you, and this one catches good crews off guard. Sometimes, after effective bronchodilator treatment, SpO₂ can briefly stay the same or even drop, though the patient is actually improving. You see, before treatment, some of the worst ventilated areas are protected by hypoxic pulmonary vasoconstriction. The body diverts blood flow away from poorly ventilated alveoli by constricting pulmonary vessels in response to hypoxemia. This means that more blood is diverted to the alveoli, which can oxygenate the blood. Then you give bronchodilators. The small airways open, but they open unevenly. And that protective vasoconstriction starts to release. So blood flow returns to alveoli that are still poorly ventilated. This creates a temporary VQ mismatch, and oxygenation can lag behind clinical improvement. And this lagging gets exacerbated by the fact that most pulse oximetry readings lag approximately 30 seconds behind actual oxygenation. So if you look at the failing oxygen saturation and think the patient is not improving, maybe this is heading in the wrong direction, you can get tricked. The takeaway is simple. In asthma, SpO₂ is an adjunct, not a verdict. And if you want to discuss concepts like this with EMS professionals from all over the world, check out our free online community by clicking the top link in the description. Now let's explore the second thing we are often taught to assess: expiratory wheezing. More wheezing feels scary, less wheezing feels better. But wheezing is just air moving through narrow tubes. When airflow drops, wheeze can fade because there's less air moving overall. So a quiet chest can be airflow failure, not improvement. And third, respiratory effort. Early on, they're restless, using their accessory muscles and speaking in short sentences. They purse their lips like this to create their own CPAP. Later, patients can look quiet and almost look like they're not in distress at all. Rising CO₂ levels can act as a sedative. Remember this: asthma patients don't crash loudly, they fade. That's exactly what happened to me in the start of my pre-hospital career. I did not pick up on the early warning signs while the physiology was heading in the wrong direction. So the best paramedics don't ask, is this asthma severe? They ask something else, and that's the framework I'll show you next. You see, world-class paramedics run a simple order every single time they assess breathing. I call it the AVT framework. And once you start thinking this way, asthma no longer feels unpredictable. We'll go through each letter in order, but here's why having a framework like this matters. You see, under pressure, your brain can only hold a few things at once. And if you don't tell it what matters first, everything feels urgent and decision-making slows down. AVT fixes that. Let's start with the first concept. Elite paramedics start by looking at the chest. How much is the chest actually rising? Is expansion symmetric? Does the patient have a long forced expiration, or are they barely moving air at all? And extremely important, the respiratory rate is adequate to facilitate gas exchange. Too low and not enough air is entering per minute, or too fast and patients often fail to breathe deeply enough. Second, they listen to the patient. Are they able to speak in full sentences? Patients who are not able to speak in full sentences, especially with asthma, is one of the findings that makes me most concerned about the respiratory status. Third, elite paramedics auscultate the lungs using a stethoscope. Is air entry present across lung sound, or does it drop off towards the bases? Do you hear wheeze everywhere, or only at the top of inspiration before it disappears? What these elite paramedics seek is airflow, the first component of our AVT framework. They ask, are adequate amounts of air moving often enough and is going to where it needs to go? When asthma kills, it's because air stops moving, and that is why airflow comes first. Remember that the air reaching the alveoli with adequate blood circulation may be much less than the volume actually moving in and out through the airway. Patients suffering a severe asthma attack may have an increased amount of dead space, air going to waste in the alveoli without proper circulation. So the real ventilation might be even lower than the airflow you see. So what does this look like in practice? You give bronchodilators and lung sounds improve with less expiratory wheeze. But as we talked about in the intro, lung sounds can easily fool you. So the lead question is, did airflow actually improve, or did the noise just stop? If the patient still can't speak in full sentences, if expiration is still prolonged, if chest movements is shallow, and fewer lung segments have good airflow on auscultation, then quieter is actually worse. Here is my golden rule. If wheeze decreases, but speech doesn't improve, airflow hasn't improved. Now that you know how to read airflow properly, the next letter in the AVT framework becomes even more important. Airflow tells you what's moving. The next important follow-up question is how long the patient can keep it moving. Most pre-hospital providers are good at spotting distress. We're much worse at spotting fatigue, like I was early in my career. But it is of the utmost importance that we catch decreased airflow long before it happens, long before the patient's respiratory muscles tire out. Elite paramedics ask, how hard are they working, and is the work sustainable? That is why the second letter in the AVT formula stands for work. Top paramedics look at posture and muscle use. They look at the sternocleidoid muscle. Remember, a muscle functions by holding one end fixed and moving the other relative to that. Normally, the sternocleidoid muscle moves the head relative to the chest. However, in respiratory distress, the muscle can fixate the head and expand the chest, acting as an accessory muscle. Look for neck muscle movement that follow the respiratory rate. Have you ever seen a patient leaning over the kitchen table like this? Same principle. Instead of using their pectoral muscles to bench press, they can fixate the arms on an object and use the pectoral muscles to expand the chest. As you know, asthma is primarily a problem of expiration, at least in the early phase. So look and palpate the muscles that specifically can be used to force air out of the lungs, like the abdominal muscles. Elite paramedics also obsess over respiratory rate, not just in asthma, but in every clinical situation. It is my favorite marker of how unwell the patient is. When patients are breathing rapidly, we need to ask how long they will be able to continue. And if the respiratory rate slows down, are they actually improving or worsening? Once again, how well the patient is able to speak in full sentences can be used. Here's my golden rule. When work of breathing and the respiratory rate decrease because the patient is better, speech improves. When the work of breathing and respiratory rate decreases because the patient is failing, speech disappears. If you're still watching, you are probably someone who takes their profession seriously and want to constantly improve yourself. That is why you should check out my free online community and come and join me and other EMS professionals from all over the world who want to connect, learn from each other, and have reliable frameworks when it really matters. Click the top link in the description now and sign up. Next, I will explain the last part of the AVT framework, the part that has changed how I approach these patients completely. Airflow tells you what's happening. Work tells you how hard they're paying for it, and the last part of the framework tells you whether or not you still have time. And this is the step that most clinicians skip because it requires comparison, not observation. Elite paramedics always ask themselves, is the patient getting better, staying the same, or tiring? Elite crews don't wait for dramatic change. They run a short loop every few minutes and look for movement. Because in asthma, everything that stays the same should scare you. That is why the last part of the AVT framework is trajectory. My golden rule for this is, if airflow and work are unchanged after treatment, the trajectory is wrong. Asthma is a dynamic disease, and if therapy is working, you should see something improve, such as more words per sentence, better chest movements, or shorter expiration. If a patient is not improving, that is a clear warning that the trajectory they're heading down is the wrong one. The same problem shows up in cardiac calls. The most dangerous ECGs don't shout. They look almost normal, just reassuring enough to delay action. If you want to see how that thinking applies to ECGs in real cases, click this video. I'll show you how confident paramedics read ECGs under pressure, what they look at first, what they ignore, and how they avoid freezing when signs are subtle. See you there.